and welcome to our CE presentation today, where we will learn about a pretreatment method that is meant to improve client engagement, retention, and outcomes when treating PTSD. I am Dr. Carl Salee. I'm a staff psychologist here at the Utah Center for Evidence-Based Treatment. I work primarily on the anxiety and mood and DBT teams, but I have a passion for trauma-informed psychotherapy and conceptualization, and in general for the topic of today's presentation, which is why I'm co-presenting. I'm joined by Dr. Alex Erdl, who is the program director for UCEBT's Trauma, Stress, and Resilience team. And then finally, our guest speaker for today is Dr. Kara Harmon from Harmoth Consulting Academy and Counseling for Evidence-Based Trauma Recovery. We're super grateful that she's here with us today as, believe it or not, she was actually one of my primary supervisors when I was on my pre-doctoral internship at the Western Colorado VA Healthcare in Grand Junction. So as the head of the Center for Post-Traumatic Growth there, she taught me pretty much everything I know about trauma treatment. And I just learned so much there, and the stuff I learned was so helpful that I'm really excited as a licensed psychologist to get to collaborate again with an old supervisor. And I'm really excited that you all get to learn from her today because the stuff she's presenting is really good. I'm super excited for this. So yeah, she'll have a chance to introduce herself a bit more later, but I'm going to kind of jump in here. Okay. So here's our accuracy, utility, and risk statement. This was sent out in all of your registration materials and marketing materials. And also if you register for the CE credits, you're going to be getting these slides. So I'm not going to reread this here for you. Just know that this is where it's in writing. The main point we want to emphasize, though, is that we are presenting on only one small part of PTSD treatment. And it is the responsibility of individual providers who are going to be delivering evidence-based therapies for PTSD to make sure that they're competently trained in that. And whatever profession you are in, please be up to date on your profession's ethics codes and whatnot, just to make sure that you're informed and know what you're doing. All right. We don't have any program notices, conflicts of interest, or commercial support to go through. We're gonna get started. So this is a general outline of the structure of today's presentation. So the first portion is going to be going over the rationale and data for why shared decision-making, commitment building, and effective conceptualization are so necessary as part of pre-treatment for PTSD. And then this is going to be followed by Dr. Harmon's portion, where she will be presenting on her psychoeducational tool that she's developed as part of this pre-treatment shared decision-making process. Then we're going to quickly map the neurobiological model that Dr. Harmon will have presented onto some of the most common EBTs. And then we're going to go over some case vignettes and practical conceptualizations so that it's more than just theoretical. We're going to try to make it practical for y'all. Just a reminder that during this presentation, please put questions in the chat. Please have videos off if you can, just to make sure we don't use up the bandwidth. The chat's going to be monitored, and we're going to be doing our best to get to questions you might have within our time constraints. And if there are any questions in the chat that we don't get to, you'll also be provided with our email addresses, so feel free to send those questions to us if we didn't get to them in the presentation. So let's go ahead and jump in here. So shared decision-making and psychoeducation, why is this necessary? The next several slides, I'm going to hope to explain that to you. So first off, it is important to realize that initiation is low and dropout is high when it comes to PTSD treatment. In this part of the presentation, I'm hoping to kind of go over what the data says about supporting the need for shared decision-making and psychoeducation. So one 2010 study Of over 20,000 different veterans found that only 66% of the veterans that were diagnosed with PTSD got any form of treatment. And of those who did get some sort of treatment, 25% of them actually received an adequate dose. Um, some more numbers from a 2016 study found that 82% of veterans who were offered PE or CPT initiated treatment, and of those, 38 and a half of them dropped out. 38.5%, sorry, not a half a veteran. 38.5% dropped out, and about 25% of the veterans who dropped out did so before their third session. So these are not great numbers when it comes to initiation and completion of the treatment. Few more pieces of data here for you. A 2013 meta-analysis found that an aggregate across 54 different randomized controlled trials, so keep in mind these are controlled trials done in research settings, found an 18.2% dropout rate for PTSD therapies. Another Australian study in 2018 found a kind of similar number of 20.9%. And then even more recently in 2021, a study, a meta-analysis of RCTs done with American veterans found about a 24.2% dropout rate, but that dropout rate increased for therapies that were specifically trauma focused. And if you're asking yourself, wait, isn't all trauma therapy specifically trauma focused? I will explain that in a minute. Don't worry, I'll get to it. Um, but yes, there is at least one evidence-based therapy for PTSD that doesn't strictly talk about the trauma that happened for somebody. So to unwrap some of the nuances in this 2013 study, um, the meta-analysis found that there was a really large variation of dropout rates across the different studies, mainly because each study was conducted slightly differently, kind of set up differently, or different ways that they did the methodology and whatnot. But when controlling for those differences in the studies and only focusing on the differences between active treatment types, no significant differences in dropout rates were found between the active trauma-focused EBTs. So these are your prolonged exposure, your cognitive processing therapy, your trauma-focused CBT, et cetera, et cetera. However, one type of evidence-based therapy actively avoids discussing the trauma, and that is called present-centered therapy. And this present-centered therapy had lower dropout rates, only 22%, than the therapies that focused on the actual trauma, which was about 36%. And this is data in just those three studies that included the present-centered therapy. So the meta-analysis, not every single study in the meta-analysis included present-centered therapy. So we need to interpret this with caution, though. We're like, oh, that's present-centered, that's lower dropout rates, great. But you might be asking, how can a therapy for trauma avoid talking about the trauma? And it's important to know that present-centered therapy was developed as a control therapy for conducting efficacy experiments on the existing modalities. And it focuses mostly on just using common therapeutic factors as the main intervention. So a quote from the VA website says, PCT, like all forms of therapy, is designed to enhance a sense of mastery. This is facilitated by psychoeducation about PTSD symptoms and an emphasis on identifying how these symptoms may influence and/or interact with current emotions and difficulties. So it was included in the research about dropout rates because it's technically listed under Division 12 of APA as an evidence-based trauma treatment for PTSD. Because the data on it from the initial research trials where it was being used as a control said, hey, this one actually works too. It's not just PE and CPT. So they included it as an EBT. The issue though is like in order to, be by the books doing PCT according to the protocol, one must avoid actively talking about the traumatic event that happened for the person or events. And that makes it not very practical to deliver in non-research settings. So, because in most clinical settings, at some point, the client is going to want to talk about their trauma, and it becomes pretty tricky to avoid doing so. Um, So everything I just presented was all data gathered from research done in controlled settings, but not in the kind of more real life clinical settings where there's less structure to ensure fidelity to the model, less, kind of uh, more risk of dropping adherence to the evidence-based guidelines. And so the research in real life clinical settings found a much higher dropout rate percentage than in the RCTs. The quick literature review that I did found this range between about 38.5 to 44% dropout from PTSD therapies, which is compared to the more 18 to 24% found in the research settings. So this begs the question, why is initiation so difficult? And why is dropout so common? And also, like, what motivates higher initiation and completion rates? And here's what some of the data says about that. So let's first talk about initiation. So what does research say about things that improve initiation rates, or at least are associated with it, and things that are associated with lower initiation rates? First off, shared decision making that includes detailed information about PTSD and a compelling treatment rationale has been found to correlate with higher initiation rates. And within that, they found additionally use of metaphor and visual aids and things like humor in the psychoeducation improve the patient recall. And I'm excited for y'all to learn from Dr. Harmon. She's one of the funniest psychologists I know. So, not to hype you up too much, Dr. Harmon. Um, so some of the top self-reported priorities that patients had for deciding to initiate PTSD treatment were receiving more and better information about what PTSD is and how it's impacting them, as well as really good quality information about what the treatment options they have available to them and like what those treatment options mean, what they would be doing. So I think informed consent, very heavy on the information side, very heavy on the consent side. Um, So let's see, what hinders it? The top two factors that were found to correlate, and when I say were found, this was in my literature review that I was doing, with lower initiation rates were negative beliefs and misconceptions about the effectiveness of treatment. In other words, when clients believed that therapy wouldn't be helpful to them, believed that it isn't necessary, or that in general therapy just doesn't work or it's wishy-washy because they don't know like what's going on, they don't know how it's going to help them, that was found to be correlated with lower initiation rates. Um, so some more research that I read, and I'm kind of solidifying it all for you guys so you don't have to read all these papers that I did, shows that several different factors were instrumental in motivating clients to initiate PTSD therapy. These factors include comprehensive discussion of treatment components, client and therapist having a good understanding of the rationale behind the treatment. We talk a lot about clients needing to have a good rationale, but it's equally important that therapists have a good rationale for why they're suggesting the treatment that they're suggesting um, before initiating. What else we got here? The client is familiar with the therapist providing the therapy before initiating. So a pre-treatment phase where you can kind of get to know each other for a few weeks is really helpful. Builds some trust, builds a working alliance. And then that the client has an opportunity to choose between evidence-based therapies. They're not just kind of pushed into one because I said so. That's really important that we don't do that. So because of this research, the VA began implementing a shared decision-making aid intervention for pretreatment. And this intervention was made to provide education and information tailored to each individual, allowing for discussion of the veteran's treatment options and goals and informed decision-making. And when they put this to the test and collected data on its effectiveness, they found that the veterans who received the shared decision-making intervention were much more likely to initiate treatment than those who didn't receive it, and they did so a lot quicker too, which in PTSD therapy, that can be an important factor. We don't want to push people into things before they're ready, but we also don't want to stall. It's important to kind of get the ball rolling because avoidance is a thing that you will learn about. Um, okay. So those last few slides were about initiation, but what does research show about the reasons associated with dropout? The biggest correlation I could find during my literature review was that more expressed emotion in the present as well as described during the trauma narrative, which they could code by reading through the narrative accounts in CPTA, CPTC, CPTA, yes, was associated with higher completion rates. So lower dropout rates, basically. And the factors that were found to correlate with higher dropout rates were a higher physiological impact. So, in other words, clients reporting feeling a higher number of, and a higher intensity of the physiological symptoms of PTSD, as well as more overgeneralized beliefs. So, examples would be like, "Oh, everything was my fault. PTSD is just something I have to deal with forever. All insert identity factor here. All men, all blank people are dangerous and can't be trusted, et cetera, et cetera. These kind of overgeneralized extreme beliefs. And then when ruling out logistical concerns, so things like, oh, it's too expensive or scheduling issues. So when we rule those things out and just focus on what's actually, in control by the therapist, um, the highest reported reason for dropping out of PTSD treatment was concerns about the treatment efficacy. So there are some really significant implications of this research that I want to emphasize here. Patients need to be aware of the physiological distress that will happen when they engage in PTSD treatment. They need to know why it's happening and what the therapy is going to be doing to help with this. It causes a lot of physiological discomfort. And it is far too often that a patient will start therapy not realizing that for time being, especially during the early stages of treatment, it's very normal that their discomfort will intensify quite a bit before it improves. Um, because these therapies actively, cue the traumatic responses on purpose. And unfortunately, without knowing that this is a normal part of the process, the patient will often think, oh, treatment's not working. I feel worse than when I started. And then they'll drop out. Um, and we don't want that to happen. That's a tragedy. So another implication is that patients who are more emotionally expressive versus avoidant tend to do better in treatment. And it's important for patients to know this data before they start because feeling your emotions instead of avoiding them is part of healing from PTSD. A catchphrase I learned from Dr. Harmon is you gotta feel it to heal it. Um, so not only do patients need to know that the physiological symptoms will be activated, but also that feeling intensely strong emotions is normal, and letting them be felt helps improve their treatment outcomes in the long run. So here's just kind of like my conclusion, condensed, too long, didn't read about all of that data. I'm gonna run through it as like a summary here. The so what, if you will. So present-centered therapy and therapies that directly address the reprocessing of trauma, so think PE, CPT, EMDR, trauma-focused CBT, so many acronyms. Both, like, they all have evidence that they work. Trauma-focused therapies seem to work a little bit better though, and they're also more practical to deliver. But present-centered therapy may have lower dropout rates, at least in controlled research settings. So what do we do about that? We want lower dropout rates, but we also want like to have a practical and slightly more efficacious treatment to use. What the data seems to suggest is that PCT may have lower dropout rates due to its emphasis on psychoeducation about PTSD symptoms and an emphasis on identifying how these symptoms influence or interact with current emotions and difficulties. Um, and the most important non-logistical factor that predicts better initiation and retention in PTSD therapy is shared decision making. That includes comprehensive psychoeducation, strong rationale, and building a good working alliance between patient and client. So as therapists, well, and by the way, I'm a psychologist, so my ethics code is with the APA. If you are in a different therapy profession, please check your own ethics codes. But we have this ethical obligation to follow the research evidence and to provide informed consent and accurate, coherent conceptualization so that we don't make things worse or just push people through something without everyone being informed on all sides, i.e., the therapist and the patient need to be on the same page and understand the problem before trying to solve it. That's therapy 101. And we don't want to make things worse or do therapies that don't have a lasting impact. We're in it to actually try to help change people's lives for good here. So this means that pre-treatment shared decision making is vital to ensure that we're doing this. And on top of that, we know that it works. There's evidence to support that pre-treatment shared decision making works. It helps. Um, so without further ado, I'm going to kind of pass things along to Dr. Harmon here, and she's going to go over the next part of our presentation about using psychoeducation as part of the pre-treatment shared decision-making process. Let me see here. Yeah, I'm going to pass this on to Dr. Harmon here.
Thank you, Dr. Sully. It is so nice to see someone that I worked with go on to be so successful and work at a great place like the Utah Center for Evidence-Based Treatment. The fact that we can be on these valued paths, that really are moving people towards healing, I think is so important. And so I was just really excited to be able to collaborate with y'all today. I did want to give everyone a little bit of an idea of who you're talking to, or maybe a little bit about my background. So the first thing I do want everyone to know is that this presentation solely represents my own views. I have been tripping around in this stuff for 15 years as a specialist with trauma treatments. And so the views I'll share today, the things that I've created, do not reflect any of the views of my employer or any other affiliation or organization. So you're going to get, just kind of world according to Harmon today. So, like I mentioned, I've been doing PTSD treatments for over 15 years. I'm a licensed psychologist in both Colorado and Utah. I'm a supervisor and trainer for predoctoral interns and graduate psychologists, which again is how I met Dr. Salih. And then I also provide consultation over the years in various avenues. So I was actually a consultant for the VA Prolonged Exposure Rollout Initiative, so taught people within the VA. I'm also the lead supervisors, Carl mentioned, for the PTSD rotation in our APA accredited predoctoral internship program. And then I also do consulting with my private practice. So one thing and it's probably good to know about me, is that I have been certified in 8 different evidence-based psychotherapies. So I'm a big believer in EBTs. What I want everyone to know, though, is my highest interest is actually in evidence-based practice. So rather than labels, I really like to look at processes of change, transdiagnostic, and looking at really those empirically supported mechanisms of change that can be used across a variety of DSM diagnosis and disorders. Yeah, I love behavioral and functional analysis. So if anyone wants to nerd out, let me know. My biggest thing that I am interested right now in is the inhibitory learning models. Um, that Abramowitz, Deacon, and Whiteside just put out an amazing book about how exposure therapy can really be used in a variety of settings. And I know that I'm a big fan of acceptance and commitment therapy, and that's another one that I know that that they all have at the Utah Center for Evidence-Based Therapy. So know that as I am sharing about this, I'm going to be very principle-based, very process-based. I don't do a lot of kind of rule and outcome sort of things. And so if you're like, hey, that, that's a little bit of a mishmash, it is. And so I'm hoping though to share a tool that can be really, really helpful. One of the things that one of my favorite metaphors is, I don't know if you all have been in this situation, but especially when I was first learning how to do these treatments back in '09, I remember that, I'd have someone and it just seemed like everything was going really well, and then they would drop, just like, we were hearing about. And that was one of the worst feelings that I ever had because I was like, oh my goodness, like, did I make them worse? Like, what happened? And so know that I have stepped in it a lot, and every time I step in it, I try to figure out what I stepped in and how to be able to do something different. So one of the things that you're going to see with the tool that I want to share with you today, and know that it's part of an entire pre-treatment process. So like Dr. Slee mentioned, usually in 2 to 4 sessions, you can really put yourself in a great position to have built, rapport, to have been able to share information that really gets you on the same page. And with this tool, the psychoeducation, I want everyone to know it's meant to educate, validate their experience. We all know how confused people can be when they come in and they're like, I don't know why I'm snapping at the kids. I don't know why I'm kicking the dog. I don't know why I can't hold down a job, right? They're going to have these real distressing circumstances. And I have found this is one of the best ways to contextualize and humanize that experience. And I really think that it's been the fastest way that I found to like build rapport, because if we can just like, I mean, Dr. Sully, he could not have set me up any better. If we can have these discussions and we can start with the end in mind, these are very difficult treatments. If we can start there and shape those realistic expectations, and I'm so glad that you'll get to hear from Dr. Ertl as well as, from me. One of the things with shared decision making is really being able to kind of set some expectations that can set you and your client up for success. And so, as you can see, my primary aim is to help increase retention. One of the things that's beyond the scope of the talk today is the role that values play. I'm a firm believer that if you have a why, you will find a how. And one of the resources that I would really recommend, this book changed my life personally and also clinically. This is going to be the book by Jenna Lejeune and Jason Luoma about values in therapy. And so know that this tool fits in to a pre-treatment process where the assessment is not only about what's going, symptomatology wise or, impairment wise. I think it's as important, if not more important, to know what gives our clients meaning. What are the desired directions for their lives? And so when you can really have that be the focus, then that shared decision-making discussion about how pain, and I'll share some of the things that I'll talk about. I really believe that pain is a given, and that the reality is that it can either be pain in vain, which is what we'll talk about with a lot of the avoidance and things that come in, or you can really have pain for value gain. And so, in addition to feel it to heal it, I'll talk about how we have to activate in order to alter the system that we target with these treatments. And And I think, I will also let them know, they'll say, there's a reason that I got tissues and a trash can. Like, we should be using these in this treatment. Um, I let them know that my job is to point out avoidance if I see it, and to have that, again, permission from them and have that be part of our partnership. And I think that, really being able to, talk about, like, you should not wanna come to my office to do this, like, if you feel slightly nauseous, if you're, like, "Oh, man, I really didn't wanna come," and they do it, that I think is the sweet spot of doing these treatments. They know why they're doing it. They know how this particular intervention, whether it's an in vivo or a worksheet, how it's part of their recovery. And I also would really encourage if shared decision making can include a loved one, someone that's in their corner. If they are open to that, that loved one, to have everyone on the same, page, because we know that these symptoms, they don't happen in a vacuum, and there tends to be a huge ripple effect. What we also know is that, again, like Carl said, if people have pain and they don't know how to interpret it, that's where you're going to get the dropout. That's where there's going to be that misinterpretation. And so you'll see that another thing I have is routine outcome monitoring. And essentially, this is measurement based care. This is the way I'll describe it is I'll say, when you go to the doctor, they're going to take your vitals. They're going to see where your temperature is. They're going to check your blood pressure. They're going to do all of these things. And if it's not apparent already, I'm a super nerd. So if you use something like the PTSD Clinical Checklist 5, I've actually correlated every one of the 20 items to the psychoeducation that I'm going to share with you. And so if you can, teach people how to give accurate responses about where the symptoms are, you can actually use that PTSD clinical checklist every single week to inform where you go, what interventions that you use, and how you really fold this into their lives. So again, it has that meaning and that purpose. So yeah, let's pop on to the next slide. Um, and I think, like so much of this, again, the conceptualization is the biggest piece, because I don't know about you all. I'll just speak for, my experience. One of the things that I think can happen is, especially if we're not using something like measurement-based care and kind of really tracking, progress and what's happening, the number one thing I believe is no one needs an evidence-based treatment, an ABT, that doesn't work for them. And so while the evidence is great, and I'm so grateful that so many people have put the time and the effort to have all of this, I always remind myself that while a lot of the evidence will send me in a direction, those statistics won't tell me about the individual in front of me. And so this is where I think having our clinical judgment and being able to conceptualize is so important. I've had times, I know in my life, when I was learning these things, and I would, I'd been practicing, and I, would go and try to deliver this intervention, and it would just fall flat. It did not follow the manual. It did not do what it was, supposed to do, or how it was in my head. And so one of the things that really got me interested specifically in what I want to share with you was I started learning about different parts of the brain, and we'll talk about it more broadly today. One of the things, though, is we're going to talk about when people are more frontal lobe, and then when they get more limbic, when they get more activated. Now, the metaphor I really like about this is I've seen people, and again, in with all my trainees and consultees and things like that, where they would deliver something and the impact would be different. And they'd be very confused, and I'd say, "Oh, well, one of the things that I'm noticing is you're tending to use a more frontal lobe intervention for this limbic system we're gonna talk about, and it doesn't tend to work." And so the metaphor that I use is it's kind of like taking antibiotics for a virus. You can take as many as you want in as many colors as you want with whatever frequency you want. But the thing is that if you cannot recognize where the client is in that moment, you will not, to my mind, be as effective as we want you to be in being able to, number one, understand what's going on yourself. Number two, being able to highlight this. And then number three, being able to use some of the strategies I'll talk about today that can help strengthen the alliance rather than have a rupture. Because again, I actually have read studies that are even higher dropout rates than what Dr. Salih, presented. And it's a bit of a tricky line. The other thing I would say about conceptualization that I think is so important is I've also seen people misinterpret pain. So we've talked about already that you kind of got to feel it to heal it, activate to alter, that sort of thing. What I would also say, though, is that we never want to forget that, psychotherapy is something we do with people, not to people. And so having a holistic view of that, client in their context. And again, it's beyond the scope, but knowing about the diversity and the cultural variables and all the things that are coming in, I think is so important because to use an example, I'll see people that will minimize what we're talking about today, which is something more around biology. And then they may really put a magnifying glass on something that culturally, may be big. And those could be, kind of judgments or things that they've grown up with. And so they can end up really feeling just discouraged that these symptoms are evidence of something that's really wrong with them, that it makes them unacceptable or unlovable or irredeemable in some way. And so I think that if you use tools like this, you'll not only strengthen the therapeutic alliance, it informs that shared decision-making process. It also can aid you in attaining flexibility with fidelity when you have agreed onto one of these treatments. Because I've had people where they're like, well, they wanted to do cognitive processing therapy account, but they don't feel like they want to actually write about what happened. So now I'm going to shift. And it's like, whoa, 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 wait. Let us look at the perpetuating mechanisms, the things that tend to make people worse. And let's make sure that we're not colluding in avoidance or sending them messages that they can't do this or that they're not strong enough or that pain, means something really terrible about them. So again, what I'm hoping to do is share a tool that gives you an understanding, your client an understanding, builds that bridge of understanding. And then one of my clients one time, he was like, yeah, you're my accountability buddy. And I really like that because it's like, yeah, I'm more than happy to keep you accountable. And so know that being aware of this sort of thing, I think can also be very valuable for us because I will let you know there are times, and it happened this week, I was nauseous while, delivering one of these treatments. I had my own fears about, oh no, what if this makes them worse? And like I mentioned, I think with this acceptance and commitment therapy and some other things, my expectation is that for this to be successful, we both have to have the willingness to be uncomfortable and move forward. And so I'm hoping, again, a little intro to this, that this tool can facilitate a discussion that can inform, empower, and provide that rationale for not only starting treatment, also finishing treatment and benefiting. And again, so that pain is not in vain, that pain can be for value gain. So the last thing that I want to kind of do to set this up is, like I mentioned, this is a part of a pre-treatment. So it's one of the first steps actually I'll do with people. The other thing is prior to using this type of tool, it's helpful to have gathered some of the following information. And pardon the cough drops. This is so we get to get all the way through this without me having some sort of spasm. So the first thing is I'm going to get a snapshot of their current distress. Okay. So it's going to be symptomatology. This is also going to be areas of impairment, as we know for the DSM, having, knowing where the functional impairment is part of not only the diagnosis, but can be very valuable information for us. I'm also going to be very thorough about questioning about safety. Because here's the thing, if someone is actively in an intimate partner, right, violence situation, if they actively have domestic violence, if their basic needs are not being filled, if that is going on, a lot of the signals from this system, if they're about the here and now, they're actually not inaccurate. And so to be able to be very mindful of that, remember that the whole reason we call it post-traumatic stress disorder is that it's about a criterion A that happened in the past that now is showing up in the present. And so again, you're going to want to be really clear to get that snapshot, to ensure there's a criterion A that is actually, we can anchor the PTSD clinical checklist to. And then I think it's as important, if not more important, to know about, again, their values, what gives them meaning, purpose, desired directions. And the reason I like to have both of those is then I can help to highlight how the symptoms are often barriers to them pursuing what really matters to them. And especially with avoidance, for a lot of people, their life gets smaller and smaller and smaller and smaller. And so being able to identify what's important to them and have them view me as someone that is able to help them pursue that and has the expertise to give them some information that they may not have known, to see themselves differently, to be able to have some hope that change is possible if they can get out of some of the ruts they're in. And, rather than repeating the same beating, we can do things that are different. And as a behaviorist, I think that's so important. If you keep doing what you're doing, you keep getting what you're getting. If you do something different, I think that there's immense possibility. And so, like I said, I will have done, and by the way, the paperwork that I use for this is only a few pages long. It's not super in depth. They will fill that out. I'll have about a 15 to 20-minute discussion. The way I put it is I like to smell what they're stepping in. So I get a good idea about that. And then once I have that PTSD clinical checklist 5, that really helps me to personalize this information. Because one of the things that I don't want to get caught in is being really global and abstract. Okay. The thing that I have found that really helps is, again, if you can have those personal parallels, if you can have some of those opportunities to, I usually ask people, I'll say, is there anything that you're really confused about? And it could be about why they're having trouble holding down a job. It could be about their temper, their anger, things that, especially before the trauma, they may have had like a really big shift. And that could be from, I used to be a social butterfly and now I'm a hermit, right? And so one of the things that I think is just so important is, again, don't use something like this in just a global broad stroke way. The more that you can personalize it, the more valuable it will become. So with that in mind, I think that gives us a bit of a intro. So we are going to do this share thing. Everyone root for me. All right. So I am going to do that screen. And then, let's see, one moment all right. So can everyone see? Let's see if this is gonna, yep, can everyone see a brain? Yes, all right. Woo, mine seems to be working today. We're very happy about that. Okay, so one of the things that I want to do, know that this is a little bit of a hybrid. Normally in that initial session, I'll spend that 15 to 20 minutes going over the information, that they've given me and getting that baseline on the PTSD clinical checklist 5. Then I usually do this pretty quick, like it'll be probably about 20 minutes. So I'm going to spend 2 to 3 times longer today because I want to not only share some of the information, I want to also share why I may have included it. Now, the other thing that you you all will notice is I want to give you an idea uh, a little bit about how I will present this, and you'll definitely get my style. Um, one of the things I do on purpose, though, is I'm gonna sorry. I'm gonna be able to utilize some of the strategies that I do. So you'll notice really corny jokes, and you may be like, "Oh my gosh, groan cringe." Okay, me too. The thing is, though, is that this is going to help you in a process-based way ascertain if that veteran or that client or whoever's in front of you actually is with you. If at any point you're getting a deer in the headlights look, they likely have become activated, and then I would jump into some coping that can help them ground and do things like that. Um, if you get like a half smile or like a roll of the eyes, I'm like, good, they're still with me. So know that if you have half smiles and rolls of the eyes, they're all welcome because that means you're still with me. So one of the things that I like to let people know about this stuff is that prior to the early 80s, despite the fact that we have had this well documented throughout history, that people, have had traumas and there were impacts. One of the things that we have seen is that it wasn't until the early 80s that we found that there were some symptoms that kind of hung together and we started giving it a name. And again, that could be post-traumatic stress disorder, acute stress disorder, things like that. Now, I think that the most valuable thing, though, in my opinion, really came about a decade and a half later. And that's where we were able to start doing brain scans. And so one of the things that I think is so helpful on this is that when people know that there's a physiological component to this, it's been a game changer for me. When people can step out of like, oh, this is a character flaw. Oh, I'm just not trying hard enough. Oh, like, fill in the blank. One of the things that I think just has real power is for them to know that there are multiple systems that are at play. So when I will talk to people, I'll say, this is just going to be kind of a simple run through. There are 2 main parts of your brain, though, that I'm going to be really curious about today. So the first one is going to be your frontal lobe. Now, I think because we don't have claws and we don't have fangs and we are soft, squishy, and delicious, the only reason that we are on the top is because we have this amazing frontal lobe. It can help us to be able, to think things through, to plan, to cooperate. Plus, we have really, really incredible, things that we're able to build. I mean, we really have an advantage that way. And I'll say, so when I think about you, and part of the paperwork, by the way, does have some pieces about values and what matters and desired directions, is I'll say, when we have that, one of the things that we're going to notice is that if you had your, kind of, your druthers, if you had your choice, it sounds like you would really be about family, or you'd really be about creativity, or, fitness, or whatever that is. And I'll say, now, the interesting thing, though, is, when you try to pursue that, though, it sounds like you're feeling blocked. And one of the hypotheses that I want to really kind of put out there is that there may be another part of your brain at play. And this is what we call a subcortical system. Now, you notice I've split up the word subcortical because I think it's important for us to, kind of break that down a bit. So sub, whether it's subway, sub-zero, subconscious, sub tends to mean below or under. And then we were just talking about the frontal cortex in that frontal lobe where we do that. And cortical and cortex have to do with thinking. So one of the most important things that I want to explore today is I really want to share more about this system with you because it may be that this is part of the reason that it's so hard to pursue things that really matter to you. Now, another thing to know about, and this is, by the way, the limbic subcortical system. If you look at a lot of what we're going to talk about today and just kind of look at brain structures overall, one of the things that's going to be really important to be aware of is this is really primitive. So we could see, in lizard brains, back in the, this really is one of the most primitive parts of the brain. And so in our frontal lobe, we have language and we're able to talk and we're able to communicate. The only language that this speaks is sensory inputs. So that's going to be exactly what it sounds like. You're going to have the taste, the touch, right? The hearing, all of these things. And as they come in through the spinal cord and your sensory organs, there's going to be a little guy. We won't spend a lot of time, but he does have like a really important job, and this is the thalamus. If you think about him, he's kind of like the male person in the brain. He does all of the sorting. So you may have taken a class where you don't actually see with your eyes. Your eyes gather data, and then the thalamus sends it to the occipital lobe. Everything you're hearing, including the melodious sound of my voice, is getting sent to your temporal lobe. So really, as these sensory inputs come in, this thalamus is just sorting where they go so they can get processed in the brain and help you function. Now, one of the things that we've established is that you have had some of these life-death situations. And so one of the pathways can be to the amygdala. Now, have you ever heard of the amygdala? And if they've watched like Waterboy with, Adam Sandler, that's usually the one that people know about. And some of them may have taken a class or whatever, but I just see if they've ever heard of this before. And the majority of people I work with, they haven't. So I'll say, well, do you mind if I give a brief overview and tell you about the two main parts, kind of the two main jobs that this thing does? And I haven't got a no yet, so we'll proceed. So I'll say the first thing that we're looking at is going to be survival. And that's a really important job. In fact, if you're not doing that job, no one cares what your second job is. And so one of the things that the amygdala is going to do is it is on constant lookout for any danger to your survival. Now, again, though, we're working with a lizard brain, so it can really only do 5 main things. Now, a lot of people have heard of the first two, fight or, and a lot of people say flight or flee. I'll say now, another one that you may have experienced yourself, or you can always think of deer in the headlights, bunny in the flashlight, is a freeze response. And so know that that's something that can also come up. And as a side note, this is really valuable, especially if you had someone in like a sexual trauma situation or something where they're like, no, I should have fought, I should have. It's like, anyway, you can, again, do parallels that help to normalize, humanize, and educate. So then I'll say, the fourth one, it's a lot more rare in humans. I've only encountered it a few times, but it is all the rage in fainting goats. So if you look up on Google, fainting goats are like, and they fall over, that's the amygdala. And the last one, I will tell you all, I think it's overlooked, and I actually think it's one of the most important. And this is where it's a failure to think. So one of the things that I will explain to people is I'll say, we at certain levels of activation, because survival is so important, what can happen is that the amygdala can actually cut off synaptic contact to your frontal lobe. It can actually hijack your brain. And a lot of people will say, man, like I don't even remember, I can't put my thoughts together. And I'll say, now, even if it doesn't do the full hijack job, one of the things that it'll do is it can physiologically impact you and do some things that makes it really hard to think. So I'll say, so the first thing is when you get stressed, what tends to happen to your breathing? And they'll say, oh, well, it tends to go up. And I'll say, yeah, I've never in my life been like, well, it's really hitting that fan, right? Typically, we're going to collarbone breathe. We're going to really have a lot of these things that start kicking in. And I'll say, because of the vagus nerve, and it's VAGUS, not fun like Las Vegas, the vagus nerve will also make it so that your heart rate will follow kind of with breathing. So if your breathing goes up, then your heart rate tends to also rise. Now, once that goes above a certain threshold, a lot of what we'll notice is you could have a rush of adrenaline. You could also have a cortisol dump. This is a stress hormone, and I'll describe it kind of like weight of the world, had to be done yesterday. A lot of urgency, a lot of vulnerability, very, very uncomfortable. And I'll say, one of the other things that can be really important to know about, and people can experience this in a myriad of different ways, is for some people, they may really notice that they get hot, right? Or they may get really sweaty, or they may get really tense, or they may get really nauseous. And so, one of the things that those tend to have in common is that physiology tends to be a sign of blood making a mad dash to large muscle groups. Because again, if the amygdala thinks that there's a danger to your survival, they're going to give you that, fight or flight. It thinks you have to kick some butt or get your butt out of there. So with this, like I said, you can make a lot of parallels. And I found this is one of the most validating things people have seen. And they can notice, that they're kind of, Mr. Jekyll or Dr. Jekyll, Mr. Hyde moments, right? To be able to say, hey, like, because of what happened to you, I think that there might be some hyperactivation here. So after I've answered the questions around this, the other thing that I will bring in is I'll say, now, you remember though, I said there were two jobs. So the second one is primitive emotion. Now remember, we're working with a lizard, and this thing has the small crayon box, and they're mostly crap colors. I'll say, so what tends to happen is that people will have mad show up, or sad, scared, shock, shame and disgust, and you can even throw guilt in there. They're all kind of crappy cousins. These are going to be a lot of the emotions that you may be experiencing. And just on an aside, this can be huge because I've had people and their point of confusion is they're like, I have a great job. I have a spouse I love. I really, my kid matters to me, and I just feel terrible all the time. And so being able, I think, to also talk about this in a way where we normalize this, and you can talk about how, when we think about our ancestors that we inherited these brains from, it wasn't the bunnies and the blueberries that got them, right? It was the threats. And so a lot of the time, what we'll notice when you have a learning history that has a lot of threats, if there are things that happen in your environment, this thing, it's trying so hard to help you out, but it's kind of like cooking with a toddler. Like, it's just kind of a big mess. Like, and so being able, I think, to help people recognize that it's like, hey, um, one of the reasons that I have a hypothesis that this, is going on is especially if they are moving in value directions and they just really can't feel it. Um, we know that hyperactivation in this system is going to increase, the negative emotion, and then we're about to talk about perceptions. And it tends to make it very hard for people to access a lot of those more frontal lobe emotions. So remember, if they're back here with mad, sad, scared, shock, shame, disgust, and that's, kind of their emotional palette, that's something that really, I think, can be be a big tell. Now, the last one that you do want to put on here, and I want to introduce this though, is that this system can do happy. However, what we tend to notice is, again, lizard brain, bless its heart, it's very A-B, very black-white. It cannot do anything that is more sophisticated. And so the only way that you can get to happy, and this is how I present it, is you have to have 100% guarantee that all of life is good right now, that it's fine, it's under control. You and us, we're bestest friends, and all's well. And I'll ask him, I'll be like, so it's a little bit of a unicorn utopia. How long, how often are you visiting that? And for so many people, they're like, oh my gosh, like that's really rough. Now, here's one thing I will put in though. If you have someone who substance use is huge, sexual acting out is huge, things like that, this side actually does correlate with a lot of those more chemical types of euphorias. And so this can be an amazing way of having a discussion that helps them make sense of maybe some of the context for some of that, especially if it happened right before, especially if we see these huge trajectory shifts. Now, I have nicknamed this side that the amygdala can either expect everlasting euphoria for everyone and everything eternally, or it'll forecast that you're finally, fatally, we'll use flawed, and forsaken forever. Okay? This is an immensely melodramatic part of the brain. And again, it is limited because if you don't have a 100, you only have a 0. If you don't have, if it's not all, it's nothing. Again, the whole reason this hyperactivated was life, death. And one of the things that can be really helpful for people to know is I'll say, the research with the DSM-5, it showed that this, post-traumatic stress disorder wasn't so much about the individual as about the trauma or stressor they were in. And I'll normalize. I was like, if I, had your history and I had that happen to me, I think my brain would have hyperactivated too. I mean, the reality is that when you're in those situations and this, comes in, that life death really makes a difference. And by the way, that's why I'm quite strict about the criterion A's and about what we want to be anchoring things to, because the life death is really going to be with that. So as we know, then with good and bad, with right or wrong, there's no middle ground. There's usually a lot of parallels here, especially if they like to right fight or blame game or things like that. Now, the one that I chose for now or never is because I think that this can really capture a lot of what we see with some of the urgency. So for some people, this will, come up where they might be a little bit more impulsive. For other people, it might come up where they're noticing that they really get in fights a lot about being punctual or what's going to happen or things like that. And I'll say, in this system, again, you're either fine or you're flawed. And there's other terms, but keeping it professional today. And if you don't have master of, the universe control inside, this will make it feel like absolute chaos. Now, another thing that I think is so important to know about this is that this is not a part of the brain that plays well in the sandbox. If you're 100% lined up and everything is there, things are going to be great. At least you have a chance of the unicorn utopia side. If, though, you're off by any fraction of a degree, then this really can get adversarial. So it can turn things into a you versus me, an us versus them. It can be friend versus foe, right? And instead of all's hell or all's well, it'll tell you all's hell. And so when we see a lot of this interpersonal kind of thing, happening that they may be confused about, this is, again, one of the hypotheses that I'm going to gather some more information on. I will also tell you, you definitely want to establish something like this, and I'll talk about an intervention you can use, because if I do my job right, I am a rodeo clown for their amygdala. They should come after me. I regularly get told to get bent. Like, this is something that, again, in my shared decision making, I'm going to let them know that I will actually be flattered if I get the attention of this thing, because what it's going to be able to do is, again, it's just part of that activate to alter, that feel it to heal it. And if I can help them negotiate in session where they activate, they display this behavior, and we are able to have a strengthening as opposed to a rupture, that is one of those elements that just can be so, so, so powerful. So with this, the last piece, and again, this is the most kind of simplified version of this. It's probably way too many versions. But with this, I'll ask them, I'll say, hey, have you ever heard an elephant never forgets? Now, I will warn you that this is getting, if I have someone that's too young, they're like, what are you talking about? But so I've started dating myself a little bit with this. But if they have heard that, I'll say, well, would you be willing to add the hippo to that? And I'll just say, the hippocampus is where we have memories. And as we all know, that's long-term potentiation. There's lots of things there. And I'll say, so, and again, this would have taken a fraction of what we've done, but I'll ask the client, I'll say, so I have a hypothesis that with the things that have happened in the past, and by the way, bless your amygdala's heart, it has all of the, A for effort. The problem is, though, is that, for instance, it can't tell the difference. It's a lizard brain. It can't tell the difference between like a group of toddlers and a group of terrorists. If there's a group and that was something to do, with what happened in the past, that can come up. It can't tell the difference between like a bullet hole and a paper cut. If there's blood, if there's harm, this can go off. It also doesn't do a very good job with being able to differentiate between emotional and physical pain because of kind of how they're co-located. And it definitely cannot tell time. So one of my theories about what might be going on for you is, due to what's happened in the past, if there is a sensory input that comes in 2024, one of the things that can happen is, I think that this can activate. It'll forecast that you're finally fatally and forsaken forever. It'll bring up memories of when you were potentially. It's going to bring in this emotion, and not only is it this emotion that's usually negative that'll come in, but it also is backed by physiology, by action urges. And by the way, this is twice as active at night, which is why I think you may not be able to sleep. And I'll tell you that moment where people can say like, oh my gosh, this makes sense, that can be just so powerful, because the amount of blame, the amount of shame, that can go on with these things. I would also encourage you that when we think about fight, we usually think about that being, them acting out. Really watch for that fight urge going in, though, because for so many of my people, that's where they're eviscerating themselves internally over some things. And so being able to have, this moment, I think, with people, and really ask, it's like, hey, does this fit? Is this something that you'd be willing to partner up with me and to see if we could get a little bit more information? I think that buy-in can just be really, really helpful. And by the way, there's coping that you can introduce. There's some other things that are sensory input oriented. The second thing, though, is very important, because once I've been able to establish a hypothesis that we're both willing to invest in, I'll say, now, would you be curious about, even though that criterion, A, happened from, years to decades ago, are you kind of curious what keeps this thing large and in charge? And typically at this point, they are. And I'll say, well, there's two main factors. Now, the first one, and again, I'm going to normalize this, because I'll say, prior to 20 minutes ago, you didn't know that this system existed. It was kind of hanging out. It was ambushing you. And so one of the things, and the reason that I outlined this in brown is so crappy. This is one of the most uncomfortable coordinated threat responses that you can experience. And so what people try to do is they try to avoid. And I have a lot of examples with this, but for today, I just said, one of the things that people will notice, especially if there was an interpersonal part of the trauma that they experienced, is they might start isolating, right? Because again, bless this little thing's heart, if it's like, being close to people meant I got hurt. So if I don't want to get hurt, this thing's solution is I'll just never get close to people again, right? And so being able to look at that can be big. And again, if you have, values, value directions where that connection is, really important to them, again, that can have a bit of a discussion there. Now, what we also have is substance use. And this has been so helpful where I'll say, and again, it's beyond the scope of today. I have things for almost every substance that go with this. But being able to let them know that, yeah, people are trying to, smoke or drown this out. And in the short term, people will get relief. And the problem though is it's kind of like having poison ivy. So you'll start scratching, you're like, oh yeah, to the left, this is great. But then the problem is it just spreads. And so being able again to know about their value directions, what give them meaning and purpose, can help you have a discussion with them to help determine, is this serving you? Is, this avoidance actually taking you in directions that matter to you? Or are you noticing that you might actually end up in more pain because you're missing out on what actually can give you that sense of vitality in your life? Now, another one, of course, is people try to stay away from anything that triggers this system. As we have talked about earlier, one of the biggest things is that my job is to get this thing's attention. And whether it's, prolonged exposure, whether it's cognitive processing therapy, whether it's written exposure therapy is another one we use. My true belief on this is that you're not able to, again, I subscribe that the brain is additive, right? So I'm not going to be able to stop the pain. However, I think if we can help make it predictable, if we can highlight the price tag of avoidance and the long-term impacts, right, with that workability, I think that those are discussions that are very, very valuable. We also will have people, and especially if people have been socialized in, specific ways, silence, is one of those. I mean, I'll joke because a lot of my clients are older. I'll say, the Duke, talking about John Wayne. I was like, yeah, he was pretty effective in his movies with strong, silent spit. The thing is, though, there was a reason he was married multiple times, y'all. And they're like, oh, that's a good point. I hadn't thought about that, because for so many people, they can act in ways that, again, they feel powerful. They feel these things that have been, kind of built into their learning history. However, again, we're trying to figure out, does that silence serve you? Or, would we maybe want to try to talk about this, to process about this? And again, values can give you a reason to do that. Now we also, and I put workaholism, but this could be too much device use. This could be any distraction. This is anything that, can really come in. And with that, that's another thing though, that's really tricky. Because what if the only place that you're getting a positive reinforcement is at work, where people really appreciate how, detail conscious you are? Or a lot of people that I know, especially if they work in law enforcement, right, or they're first responders, they actually get reinforced for a lot of this, and they may have built a reputation on it. They may have a lot of things going that way. And so again, being able to get to know the person in front of you and how this is working or not working for them, and having those shared decision-making conversations, I think is huge. And lastly, emotional numbing. And one of the things that I'll let people know is sometimes this is purposeful, and people are behaving in ways that will purposely bring that down. Could be cutting, burning, things like that, or choosing kind of not to feel. Know though that this can also just be, I mean, if you look at this system, it's like playing a game of like Russian roulette, and you're not going to win. And so for a lot of people, they just kind of numb out. And I want to help normalize that. Again, I'm going to highlight what that's costing them. And I think that, again, that can be that important part of exploration with that. Now, anytime there is avoidance, right? I'm also going to be looking for what we call unhelpful beliefs. Now, you may recognize this term from prolonged exposure. You may recognize the areas that we're going to go over from like cognitive processing therapy. I think that here, again, there's been so much amazing research and people who have dedicated their lives, whether, it's Dr. Foa or Dr. Resick to this. I just think that being able to be aware of this is so important because the first area that people really tend to get nailed in because there was a danger to their survival is going to be safety. Right. And so one of the things that we're going to notice is people get preoccupied. And there's something, I call them avoidance behaviors. Some people call them safety behaviors. But anyway, with avoidance behaviors, people will actually start behaving differently again so that they don't have to feel the system go off. Being able to identify those is going to be huge because if they're engaging in behaviors where their amygdala can take credit for their well-being, where it's like, well, the only reason, that you haven't been, shivved in Walmart is because, you keep your back to walls or you go at, 11 p.m. at night or things like that. We're going to watch out for that. The other thing that I really want to put in here is the reason we call them unhelpful beliefs instead of like stupid or I can't believe you thought that beliefs is because a lot of the time these beliefs would have had utility in the past. And so we get really curious about that, where it's like, is that a belief that has ever served them? Is that a belief that maybe saved their life? I mean, watch your six, don't trust strangers, things like that. In certain contexts, that's going to be super important. Typically, though, and there's a reason they're in your office right now, though, and it's probably related to that. So in addition to safety, we're also going to look at trust, and this could be trust with self, this could be trust with others, trust, with the world. Um, One thing that I'll add in how I think about this is people who have had learning histories where there was betrayal. I actually think betrayal is kind of the bridge between the safety and the trust because you trusted someone to keep you safe and they probably didn't, or circumstances or whatever it is. So listening for that can be pretty helpful. We've already talked about kind of power control. And this is where being able to say, hey, one of the reasons or one of the ways that people try to feel a greatest sense of power control is to be avoidant. And so if you get caught, and I teach people how to listen for primary, secondary, and tertiary feedback loops that come in. If you can help identify that though, and then again, give another option, do something, that can kind of help them to recognize that as powerful as they might feel, or as in control as they might feel, the actual impact on their relationships or on their ability to do things isn't there. I think that's pretty big to be able to highlight and consider if they might be willing to shift that. Now, esteem is something where, again, this could be how they feel about themselves, how they feel about others, how they feel about the world. We will see very big shifts. And I want to highlight this as providers. One of the mistakes that I will see people, and again, they're well-intentioned, one of the things I'll see them do as providers is someone will make a comment and it's going to be a broad comment. Again, this is a lizard brain, maybe, right? And it could be about, gender. It could be about a race. It could be about any characteristic, age or whatever it is. And people will be like, "Oh my gosh, like I'm such a horrible person. I have this thought." And it's like, well, wait a minute. Like, let's look at what would have gotten coded back when you had the trauma. Because remember, this thing is not politically correct. And one of the things, and this is again a whole other kind of seminar, but when we look at different types of learning, right? So we'll have like conditioning learning, Pavlov, ring the bell, salivate. And then we have operant learning, right? That's going to be more about reinforcements and things like that. The interesting thing about like conditioned learning or respondent learning is that takes place without any, in most cases, without any frontal lobe awareness. And so for people to know that there is a part of their brain that can generate its own thoughts or perceptions, that has its own emotional palette, that can not only have the physiology impacts that we have here, but I mean, if you reach about the HPA axis, if you look at all of these things, I mean, there are massive impacts. And for so many people, they'll say, oh, well, I'm just a bad person. Like, I have this pain, or I've reacted this way, or I have this thought. And it's like, whoa, 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 whoa. Again, this is going to be grist for the mill in being able to talk about this. We also, intimacy, I use more closeness. With intimacy, and especially if there has been sexual trauma, that can be really, really applicable because people like, oh, like sex. And it's like, yes, and it's much bigger than that. So this part of the brain cannot differentiate between like physical vulnerability and like emotional vulnerability. And so a lot of the time people say, man, I'm trying to make friends, but then I just feel, really threatened, and I just like push them right out. And it's like, yeah, let's look if that might be part of this, hyperactivated system. And so, like I mentioned, I just think that you've probably heard this information in different ways. You've read it in different articles, or maybe it was in a book, or, things. I have found, though, through a lot of trial and error, that being able to present it this way has been something that has been super, super helpful. And like I said, I'm someone who is much more process based. And so being able to recognize when this coordinated response, this coordinated threat response comes into the picture is something that is invaluable, whether it's in my office, whether it's assigning an in vivo exposure with prolonged exposure. Again, I'm not going to stop the pain. However, what I will say is I can help make it more predictable. So if like, all right, you're about to go do this, you're gonna go and go on a walk in your neighborhood, and we're not gonna have you looking behind you, and we're not gonna be doing that. What do you think? What thoughts will show up? What emotions will let you know that we've got this thing's, attention? What sort of action urges are you gonna feel? And what physiology would are you willing to feel that in order to grow? And also let them know, like, are there images that'll come up? Are there things from the past, right? And so one of the things that I found that is most helpful, and again, being more, we are almost to the end. I am very proud of my throat. One of the things that can be really helpful about this is, and again, humor is a huge part of this. I found that this strengthens the alliance that I have with people. And it also really can be instrumental in highlighting things. Is if you give the amygdala, so it's kind of a weird word anyway, right? If you can give that a nickname. And so some people, if they like South Park, they'll call it Cartman. Some people might call it Cruella. Whatever that is, if I can then use that, and again, that's from ACT, it's a physicalizing kind of intervention. If you are able to use that sort of thing to say, oh man, and especially if you're having one of those interactions where there's activation in the room, you can then speak to them about their PTSD and align with them so that you can maintain and you can strengthen that therapeutic alliance you have. You can highlight when the activation has come into the room. You're able to also let them know about the behaviors and the different, kind of things that can come in. And I had someone like nickname it Pitts, they're like, yeah, I can't take advice from a dude named Pitts. I was like, get it, man. Right. So what we can do is, again, once you are aware of this system, I think it makes it less likely that you are going to use frontal lobe interventions on a limbic system, right? So less likely that you'll take that antibiotic for a virus. And you can use coping that is then specific to this system. And one of the things that I'll put out there is that for tip skills, right? That's where the reason, and I'm so grateful for Marshall Linehan, the reason those can be so effective is they actually speak the language of this system. Because, for instance, if we do something like dive response, right? You're making it cold, damp, your eyes are closed, your breath is held, and you're leaning forward. And dive response is, by the way, when you can use ice, a bag of ice, or really cold water to submerge your face into. You hold your breath. I call it pulling a little mermaid because you come up and then you go back down. That kind of short-term coping is so much more effective than trying to talk to this thing. It's like honey badger. It doesn't give a crap, right? So being able to be aware of what is showing up in the room, to be able to anticipate it, to be able to add an element of prediction and have that take place in a context of meaning, where they know that if we do this treatment correctly, you will not want to see my face, right? I mean, you will, your frontal lobe will, but Cartman, he's not having it, right? So being able to set up these dynamics, I have found that, yeah, I don't step in it like I used to, especially with something like cognitive processing therapy, to be able to say, hey, do we think that thought is you and your values? Or do we think that that might be, a stuck point for a worksheet? Again, with prolonged exposure and, all of the in vivo kind of things. So I know that that's bringing me really close to the time I have. I just am so grateful to be able, though, to share some of this. And again, this is one tool within a pre-treatment. There's other tools that help, set up some of that shared decision-making discussion where you can actually personalize this to who you're talking to and or their loved one. But I do hope that this is something that really might resonate, that even if you've heard the information, before in one way or another, that maybe this helps consolidate it in a different way. And again, build some of that bridge of understanding between you and your clients. And so, I was going to say, I will pass the baton virtually. But hope that felt kind of helpful. And I think that my contact info, I think, is in the slide deck and will be that next one. So Dr. Ertl, let me know when to stop sharing and we'll get this baton passed on.
Real quick. Oh, if you have a brief 2 minutes, there was one Q&A
Yeah.
question that we wanted to maybe address.
And sorry, just got it. So yeah, dive in, Dr. Sully.
It said, oh, where is it? Okay. This is regarding the feel it to heal it. I struggle with pacing and planning slash resourcing when clients have a lot going on. They want to process, EMDR usually, and I want them to process, but it's hard when they have to go back out into stressful lives and a world that is melting around us.
Mhm.
What advice do you have for supporting clients in their coping and functioning when they're feeling it to heal it?
So I think that, again, this will be a very rough kind of bullet point sort of thing. I think number one is that we want to look at our own perceptions. And this is regarding ourselves, our clients, and the world. One of the things that I help people do is to really listen out for linguistic cues that can let us as well as the client know that a lot of the time there could be some activation in the equation. So again, we have a lot of the terms here. I have other, kind of write-ups. It's about what I would say real briefly is it's to validate and then also differentiate, if that makes sense. Because the reality for me is that my brain, and we all have this, and I let all my clients know, like, I have this, you have this, all of us, or have this going on. And so being able to essentially translate what the feeling, what the bodily experience kind of is into language is a really key step, because once you have language, then the frontal lobe can kind of play and you can actually use a lot of the skills. So I would say, number one, if you're having activation where you're not able to really think, please use something like tip skills and get, where you have actually access, because failure to think is real. And failure to think is the saboteur of most things. Secondly, once you're in your frontal lobe, finding whatever means that you use to kind of translate that and capture that language, and then being able to look at that to validate the valid. I would heavily encourage you to like differentiate though, so that you're not validating the invalid. And again, that's going to be more Dr. Linehan and things like that. Because one of the things that I have found is that the more intense an emotion is, the more likely we are to salute it. And that is where all of us get in trouble. One of my favorite social psychologists is Jonathan Haidt. And he has written extensively, whether it's The Righteous Mind, Coddling of the American Mind, The Anxious Generation, about how, and by the way, he specializes in morality, impact of more macro factors kind of on our behaviors and things like that. So I would say that the most comforting thing to me has been that, like, never take the rough draft from your mind, especially if there's really high emotion in it. Being able to, again, use coping so that you can bring down failure to think, you can get into that frontal lobe, you can translate that experience, you can validate and differentiate, and then use values as a compass to help you move forward in the ways that you can. I love the discussion about, you've got your sphere of concern, which is anything you could ever be worried about. And you also have your sphere of influence. And so figuring out where those two kind of come in, and then again, just, coping, validating the valid, being able to differentiate and find where, like, we can't do everything. I'm convinced though that that doesn't mean we can do nothing, right? So being frontal lobe is figuring out that something. And sometimes that really is that self-care that is a prerequisite for almost anything else. Some of that is, getting involved with our communities. It's being able to take the steps that we can. So I hope that that's kind of a good enough answer with a broad brushstroke kind of bullet point. I think though it's a process again. There's not really a rule book, I think, that you use with everyone. It's going to be who's in front of you, where you are, what the situation is, what resources you have, what kind of power you have, what sort of things that you have access to.
And I'll give an additional answer to this question. I saw you mentioned kind of working through an EMDR lens, and I would say this is where our calm or safe place skills are really important, that we're really setting our clients up for success by doing those early phase coping skills and installing those. Also, container can be really helpful for helping people have a sense of, I've wrapped this up, I'm able to contain this from one session to another. So to use a little bit of the EMDR language there. Also one too, I was going to give a little bit of a shout out to this at the end of the presentation, but it's a little bit relevant now. That there has been some movement in the field that I've seen, and this is something that we're doing at UC-EBT to move toward an intensive style of trauma treatment. So whereas it may have been, 45-minute sessions week to week to week, where people really need to hold that stability, open it up, close it, open it up, close it, manage their lives all through in. We've had some success moving towards the style where we're going to do multiple hours of therapy in one day. That way we're cutting out a lot of time, not having to open and close it. And also, we can do this in a way that people don't have to find that stability through the hard stuff for 3+ months. Rather, it can be, I need to hold on to this for a week or two, maybe even, if it's a single incident trauma, maybe it's something like we can work that out in a day or so. So just want to kind of give an alternative answer of, there's ways to help reduce the and minimize the need for holding this between session and keeping life together, because life is still going on for people.
And the research, Dr. Rowe, I'm so glad you brought that up, is I do something called masked delivery. And so, for instance, I've done prolonged exposure with someone in 13 days. They were a teacher, they had a 2-week break, and we nailed it, right? So, being able, again, in that shared decision making discussion, I think that people can overlook logistics. And again, people have a lot that's going on. It could be work schedules, it could be, childcare, it could be all of these sort of things. So I am so glad that you brought that up, because what we're noticing about the processes of change with this part of the brain is that dosing, number one, matters. And number two, you can actually, just like you're talking about, get people through these treatments faster and really have some lasting results. I mean, the research is showing the efficacy is super high. I did also get a chance to read through this. Did we want to, do we have time for me to speak about kind of the twice as active at night sort of thing? It'll be pretty brief. So in essence, someone asked, why would this be twice as active at night? Matthew Walker has a really great book about why we sleep. The thing is that if you think about when our ancestors were most vulnerable, it was at night. We don't have great vision. We don't have like great senses. So if that is taken out of the equation, that's one of the theories that is there for why it is so difficult. The other thing that Matthew Walker talks about is that if you don't have a trauma history, you typically will have at least 1 hour out of your night that you don't have norepinephrine or adrenaline rushing into the system. And he uses this amazing metaphor where he says, your brain is able to go through what happened that day and remove the information-rich fruit from the bitter emotional rind. Once you have a lot like a trauma history that activates this brain, you now no longer get that break from the adrenaline or the norepinephrine. And that's why frequently we will pair this with something that's an alpha-1 beta blocker, so that when the adrenaline is released, prazosin is one. I work with a colleague to prescribe that. That essentially will be able to block a lot of that, where you don't absorb it all. There's also doxazosin is another one that doesn't cross the blood-brain barrier but can be effective. So hopefully that's helpful as well. And should I stop sharing at this point? We good? All right.
Let's see, are you seeing this slide that says mapping neurobiology? Okay. Carl, do you want to take us away?
Yes. I was reading the chat and I was like, oh wait, it's my turn. Okay, so yeah, we're gonna just really briefly map this model onto some of the most common treatments, really quickly run through that, and then Alex is gonna provide the case vignettes. So you can go to the next slide, Alex. Just a quick note on diversity that we really want to kind of touch on is that a large majority of the research that I reviewed during the first part of this was really focused on veterans, and a lot of research so far doesn't necessarily take into account other identity differences, even if it's not on veterans. That's just a limit. Can't control that per se. But what's important, I think Dr. Harmon kind of mentioned this in her part, is that PTSD affects everybody's brain basically the same. Well, in a similar matter, we all have amygdalas. That's a part of every human brain. And so, but reasons for developing PTSD can be pretty diverse and dependent on someone's unique biological makeup, their social learning history, other epigenetic factors. So just keep that into account. We can't cover everything in this topic. So, and things like discrimination for identity-based reasons can be experienced as traumatic, and they're oftentimes a bit more complex to conceptualize than discrete events are. I think this psychoeducation can touch on that, and just keep in mind, like the criterion A piece is is a little bit more what we've like focused on today. But what's really important about this kind of note on diversity is that when it really comes down to it, it makes tailoring the pre-treatment psychoeducation and shared decision making, you know, to the unique presentation of the person who is in front of you. We're treating a person who has, you know, multitudes of identity factors and social learning history. And even though the way that our brains and bodies will react to trauma is fairly predictable across identity factors, because we all have amygdalas, how it shows up in behavior and is expressed contextually has to be assessed on a very case by case basis, hence the individualized pre-treatment that we need to do. And choosing an effective treatment cannot really be a one size fits all approach. It takes shared decision making. So, next slide, Alex. So just really briefly, if avoidance and unhelpful beliefs are the things that keep PTSD large and in charge, talk a little bit about how PE works, prolonged exposure. It focuses primarily on the avoidance en route to the trauma, at least to start. So the goal of PE being to create new learning in the brain that can kind of add on top of the old trauma learning. Dr. Herman said our experience is additive. We can't really remove old connections, but we can create new ones. Um, and so it does so by approaching the unwanted experiences rather than trying to avoid them. And it approaches external stimuli, so the sensory inputs through in vivo exposures, and the internal, more memory-based cues by using imaginal exposures. So if someone can stay with the previously avoided experiences for long enough for the distress to naturally subside without behaving in a way that reinforces the amygdala's belief, then their brain can learn that they can actually experience this type of stimulus that used to cause distress, and they can still be safe. So the idea being to behave your way into new thinking, kind of little catchphrase. So next slide, Alex. So if avoidance and unhelpful beliefs are what keep PTSD large and in charge, then CPT works primarily on the unhelpful beliefs side of things, through the cognitive restructuring of those stuck points or unhelpful beliefs. So think the safety, trust, power control, intimacy, and esteem that people develop after experiencing the traumatic event. So stuck points tend to be really unhelpful in the present day, overgeneralized, extreme, very strong. Kind of Dr. Harmon walked us through some of that. So the thing is that the cognitive restructuring tends to only work long term if while like during and after we are restructuring the stuck points, the client is able to behave in line with the new, more helpful beliefs that we're trying to install. So new learning doesn't stick around in our brains unless new behavior also reinforces it. And so there are still definitely exposure elements to CPT, but kind of more like on the back end versus taking like the direct approach that prolonged exposure would. So the idea there being to kind of let new beliefs lead to new behavior, but it's important as therapists to emphasize we can't ignore the new behavior part as well. Yeah. Next slide, Alex.
And I'll take it from here and talk a little bit about how this tool, this model might map onto EMDR. I hope you're hearing how through a client's eyes, if they have this basic neurobiological model first, then these treatments make a little bit more sense to them. So just a very brief overview, EMDR in a protocol, we're going to ask people to recall a memory or an image, describe associated cognitions, emotions, bodily sensations, and apply bilateral stimulation. So if we go back to that model that Dr. Harmon showed us, we can help the client see, oh, there's this entire portion around how thinking is around, there's hundreds of problems, nothing is wrong, everything is death. We're going to be addressing some of these negative cognitions, labeling them, helping you move towards installing more positive and useful cognitions. We'll be using cognitive interweaves or interventions to help you consider new information through EMDR. We're also going to kind of look at that hippocampus part where your amygdala is being fueled directly by memories. We'll be identifying memories, and pretty similar to PE, we'll be doing approach behaviors rather than avoidant behaviors to help with this. And also we're going to call out what are the sensations within your body. There's all these physiological changes going on during a response where the amygdala is large and in charge. So we're going to help find ways to bring calm and relaxation to these parts of the body through EMDR. So with our few minutes left here, I prepared 2 vignettes, but maybe we'll just take time to more so focus on one. I'm hoping that we can see a little bit of how we can tailor our speech and our treatment and our conceptualization to individuals, rather than having someone come in and, for instance, we say, here are the different criteria for PTSD through the DSM, which doesn't really just give us a really large global framework or conceptualization. We can more so share something along the lines of this tool or another way of understanding PTSD and really saying, this is how I think this is applying to your life. So I'm going to move us into looking through a first vignette here. This is not a particular client. This is more of an amalgamation of multiple clients who commonly show up to PTSD treatment. Clara is a 27-year-old white cisgender bisexual woman who was assaulted by a male acquaintance at a party 3 years ago. Since the incident, she describes her life as being in a constant state of vigilance. I feel like I can never relax, she says during therapy. At work, her performance suffers because she is hyper-focused on the exact whereabouts of her male coworkers to the point where she cannot sustain attention on her own task. Her nights are restless. She wakes up drenched in sweat with nightmares whose content represent aspects of the assault. As a result, she avoids sleeping altogether some nights, leaving her exhausted and irritable during the day. Clara avoids social events, particularly those where alcohol might be present, fearing a loss of control or letting my guard down. She also feels a deep sense of shame and often isolates herself, convinced that others can sense her brokenness. Clara often experiences panic, triggered by seemingly benign things like certain music or the sounds of men's voices. Clara says that her body betrays her heart races, her hands shake, and her stomach churns without warning throughout her week. Sometimes I feel like I'm going crazy, she admits. She also experiences feelings of numbness and detachment, describing days where she feels like she's just going through the motions and unable to connect emotionally with loved ones. So at least in my style, if Claire were to show up in my office, one of the things I really do like to emphasize, aligned with what we've heard from the other presenters today, is helping our clients understand what is happening here is not about you being broken. This is about your nervous system is trying to keep you safe. And nearly all the things that you're describing to me are life-saving in a crisis. It's really helpful for us as a species to have these built in, to have these be automatic, to have these occur without our need to slowly stop and think about this. But we find that they're debilitating when they're happening chronically, when they're happening out of context, where you actually are safer. Sometimes I almost think of these things like an overly helpful friend who ends up just kind of making more trouble for you. Maybe that person in your life who's constantly texting you, checking in on you to the point where it's annoying. There's a really good intention here. That friend might be awesome to have at a time of hardship, but when you're just going about your day-to-day, it's not helpful having them show up at your door all the time. I like to really help people understand and reassure them. It's not that you're broken. You mentioned you feel like you're going crazy. I don't think you're going crazy. It's that your body is doing all these things to cope, but these have now become obsolete because you are in safer environments and they don't fit because they're happening chronically in the wrong place. So a couple things, if we had met with Clara and described the neurobiology in the way that Dr. Harmon had, we could help point out some of the things that are going on for her and help her identify, oh, this actually makes sense given this context. So if we highlight her report of being in a constant state of vigilance, her hyper focus on the exact whereabouts of other men in the office, we could recognize these, hey, these are sensory inputs that used to be either neutral or positive for you, but now they get routed via the thalamus to the amygdala and interpreted as signs of danger. So again, we want to help her understand that the amygdala, her nervous system as a whole, trying to keep her immediately safe, and so has identified these things that for a period of time in her life, in an instance, were dangerous. So now has labeled them as dangerous and helps keep her focused on them, and keeps her on alert. It makes sense that she's attuned into this. We could almost say, like, if there were lions in your office, you would probably be better off attending to where are these dangerous animals. And now your amygdala has labeled men as just as dangerous. So it makes sense this is happening. We could highlight to her, oh yes, of course, what's going on at night, as we've been having this discussion in the chat, explaining that this input from sensory input to thalamus to amygdala, this system's twice as active at night. So of course, there's going to be an increased intensity in nightmares. Of course, you're going to be remembering and be sensitized to certain content at that time, feeling generally restless. Again, as a species, we're quite vulnerable at night. We don't have great eyesight. So it's important that our alert systems are on extra alert. She's mentioned shame, isolating herself, feeling this loss of control. We can kind of point back to, yeah, shame was one of these emotions that are associated with amygdala activity. So it makes sense that we've got these I am bad, I am wrong kind of type emotional experiences happening, as well as beliefs showing up for you. Yeah, makes total sense. Now that you've come to view the world as so dangerous, of course, you're going to want to find a way to have control again, whether that be not drinking, whether that be avoiding. And yeah, I'm hearing that when you're around other people, this system of that we've talked about activates and shame increases. So it makes total sense that you'd want to isolate. And lastly, we could point out to her that all or most of these physiological symptoms that are really distressing and unpleasant, these things are life-saving during urgent and dangerous times. So it's really disruptive and also would ready her for fight or flight if there was an actual emergency. And we can also see and kind of hear, this is going on chronically for you. It makes sense that you're kind of going back and forth between this panic state and then this kind of hypoarousal with exhaustion, numbness, detachment. You're chronically sleep deprived. You're probably having chronically elevated levels of cortisol. It makes total sense for that. I think just with seeing our time that we're 11:57, we'll leave the vignette here, but I was just planning on this next slide. We can start introducing very personalized overviews of what these different treatments might look like for Claire when we're kind of working in that shared decision model. So we might even plug in of like, hey, within CPT, I mentioned and kind of feel some of these beliefs that you're saying. I'm not allowed to relax. Something bad will happen if I let go of control. Maybe men are dangerous. So we start plugging those in as potential stuck points for her when we're explaining this is what CPT is. This is how it's going to address those things. So just making sure when we are talking about these treatment options, hopefully we're talking about treatment options, and hopefully we're making them really personalized so they can understand, oh, this is what it looks like in my experience, how it fits into my experience. This is what treatment would look like moving ahead. So we've got that really strong informed consent. So we won't get to the second vignette, but I'm hoping that for everyone that you're getting a sense of what the main points here are to include your clients in a prolonged experience of pre-treatment where they're getting lots of education, where they're getting opportunities to give their input, where they're getting opportunities to be informed about what their treatment options are, what that would look like. We really do want them coming away with this sense of like, this makes sense now for me. My nervous system as a whole is trying to protect me, but it's doing it in a way that's not helpful anymore. I think the last slide that we had on here, just a shout out again to the intensive style of doing work. That's something that myself and Dr. Stephanie Taylor have started in recent months here doing at UCEBT, and we're finding that it is a really effective way of addressing some of these pieces that came up of how do we manage this week to week. You know, people, if they don't need to show up every week for 3 months, there's a lower rate of dropout if they only need to show up a couple times or one time even to do some of this work. I'm gonna stop sharing my screen here. And bring us back. So it looks like everyone, you've got our information, our contact information for some of these questions that came up that we really just kind of don't have the space to be discussing today. Please reach out. We'd love to have some communication with you all. We hope this has been valuable for everybody. We really do hope that you can take away something, reduce your own personal dropout rate, increase your client retention, do good work, continue on the healing out there. So I don't know if there's anything my co-presenters want to say. Thank you for letting me be part of the special warm and fuzzies that you've got as supervisee and supervisor. I'm a little jealous right now. So thanks for letting me present with you all.
And thanks for letting me be a part of it. I hope it was helpful, and know that I'm so grateful to be on this path with so many providers who showed up today and are dedicated to try to know how to do better and be more efficacious and really help people to healing.
Yeah, same. I'm grateful that you all attended and hope you gain a lot of value from the content we presented today. So, yeah.
I know I'll be,
Carl, good to see you again, and Dr.
Yeah,
Rowan
you
and
too.
everyone at UCEBT. Thank y'all.
if nothing else, I'll be taking away validation. That's okay that most of my jokes land with half smiles and rolls of the eyes. In all aspects of my life. So thank you for that reassurance there, Dr. Harmon.
You're welcome. All right, y'all. Thank you.